can be dependent on the person doing the measurements. It is important that dietitians acquire and maintain these measurement skills through consistent practice. Z-scores can be calculated using WHO reference data or reference tools such as peditools.org. For patients 6 years and older, TSFT can be compared to normative data to determine percentiles or Z-scores. Hand grip strength. Hand grip strength is measured by the amount of static force that a hand can squeeze around a dynamometer device. Table 1.13. It is a predictor of nutrition status and a marker of muscle quality. Normative data for hand grip strength is available and stratified by gender and age. See Bohannon et al. In references. Static force measurements indicate if an individual has weak, normal, or strong hand strength based upon stratified norms. Analysis demonstrates that males at all ages show higher grip strength than females, with grip strength peaking in all genders in the 4th decade of life. Hand grip strength and BMI have been loosely correlated, with underweight and overweight individuals having lower grip strength than normal weight individuals. Interpreting growth measurements. Growth charts are an essential tool in pediatric growth assessment. They allow the dietitian to plot measurements over time, view trends, and compare patients to normative data. Standard growth charts. Growth charts are used to compare anthropometric measurements against age, gender, and population standards. Appendix A. Percentile ranges and standard deviation. Z-scores are used to assess both short-term nutrition status and long-term growth trends. In children, weight, for length, BMI, for age, and length height, for age. Z-scores are utilized to diagnose malnutrition based on undernutrition. Chapter 10. Overnutrition is based on BMI percentiles. Chapter 25. Serial anthropometric measurements are an essential component of nutrition assessment. Although some information can be gathered from measurements at a single point in time, historical measurements help the dietitian understand the child's growth pattern and determine if there is concern for growth faltering. Figure 1.1. Whenever possible, the dietitian should obtain historical data to accurately assess a child's growth pattern. Age. Appropriate weight gain standards are based on WHO growth chart data from 0 to 24 months and Centers for Disease Control and Prevention. CDC growth chart data from 2 to 18 years. Table 1.14. When assessing a child's growth, the dietitian can compare current weight gain velocity and linear growth velocity to the standards to determine if a patient is growing appropriately. This is especially useful in assessing acute changes, 3 months, in the hospital or outpatient setting, as these changes may be more difficult to discern from the growth chart alone. Length velocity norms are available on the WHO website free of charge. https www.who.int tools child growth standards. WHO versus CDC growth charts in the USA. The WHO growth chart is recommended from birth to age 24 months. In 2006, the WHO released updated international growth standards which defined normal growth for children living in environments that supported optimal development. The USA was one of the 6 countries to be included in the data set. WHO growth charts establish growth of a breastfed infant as the norm and provide a better description of physiological growth in infancy than the alternative CDC growth charts for infants. The CDC recommends transition to the CDC growth chart for children aged 2 years and older. Of note, this recommended approach of transitioning between growth chart standards can lead to shifts in growth percentiles for children at age 2 years. The WHO growth chart for older children is, however, available to provide information up to age 5, for children from 2 to 5 years of age. Similar methods were used to collect data in both the WHO and CDC populations. Specialty growth charts for specific populations where standard growth is not the norm. Specialty growth charts are used to assess nutrition status. Conditions that alter growth that may require specific growth charts include chromosomal disorders, genetic disorders, and neurological disorders that impair ambulation. Infants born preterm also require population-specific growth charts. Chapter 12. See Chapter 21 for more information on assessing growth in special populations. Z-scores on a growth chart. A Z-score, otherwise called a standard deviation score, is defined as a score that indicates how far a measurement is away from the mean score, which is a Z-score of 0. This score is utilized to assess nutrition status, monitor anthropometric trends, and diagnose malnutrition due to undernutrition. Z-scores are more precise than percentile ranges and are recognized as the gold standard for analysis of anthropometric data. Healthy children typically grow parallel to the mean line, but minor variations in Z-scores are incredibly common, and growth chart assessment is a skill that is learned over time. However, children who are at risk of malnutrition will demonstrate a decline of Z-score lines. Z-scores outside +2 and -2, which reflect scores that are 2 standard deviations above and below the median respectively, are likely to be abnormal. Malnutrition due to undernutrition in the pediatric population is diagnosed by Z-scores for weight, for length, BMI, length, for age, or height, for age. Chapter 10. Additional growth assessment tools. Mid-parental height. Adult heights of both parents, along with parental patterns of growth in childhood, strongly influence their child's growth velocity and ultimate height. An estimate of a child's adult height potential can be obtained by calculation of the mid-parental height, MPH. MPH can be calculated using the following formulas. MPH for females, cm, average of parents' heights in cm 6.5 equals plus MPH for males, cm, average of parents' heights in cm 6.5. A child's final height typically falls within 2 standard deviations above or below the calculated MPH. Children growing outside of this range may have impaired linear growth due to malnutrition or other causes. Ideal body weight. The percent of IBW is another method of assessing proportionality. IBW is used in some patient populations to determine nutrition risk or calculate nutrient needs. For infants 0-24 months old, the IBW is the 50th percentile for the infant's age on the weight for length chart. For children 2-18 years old, the ideal BMI is the 50th percentile for the child's age on the BMI for age chart. This must then be converted into IBW by multiplying by the square of the height, M2. Weight age and height age. Weight age is a tool that dietitians can use for patients that are underweight. Figure 1.2. To determine weight age, on the growth chart follow the patient's current weight horizontally to the 50th percentile. At the 50th percentile, looking vertically, find the corresponding age, which is the patient's weight age. Weight age can help the dietitian visualize the size of the patient. It can also be used to set weight gain goals that will result in catch-up growth. Height age can be calculated using the same method on the length for age or height for age chart. Figure 1.2. Follow the patient's current length or height horizontally to the 50th percentile and then follow this vertically to determine their length or height age. Height age is useful in determining nutrient needs in patient-specific medical conditions, including renal disease. See Chapter 20. Diagnosis of underweight and overweight. Children who are malnourished due to undernutrition are diagnosed using multiple criteria including current anthropometric data, anthropometric changes, and reported oral intake. Anthropometric data expressed in Z-scores aid in classifying degree of undernutrition. Malnutrition criteria assess weight trends when evaluating degree of severity. Thus, not all patients who are undernourished are underweight for age or height. When a child is malnourished, her weight is affected first. She will demonstrate weight loss or slow weight gain that results in a decrease in weight for age, Z-score. If malnutrition is not corrected, linear growth will begin to falter. This will result in decreased length for age or height for age, Z-scores. The weight for length or BMI for age, Z-score may improve, but this is due to the decreasing length or height for age percentile, not correction of malnutrition. If malnutrition is not corrected, this may also result in slowing of brain growth leading to decreased head circumference. Z-scores. See Chapter 10 for more details about the effects of pediatric malnutrition on growth and development. Diagnosis of overweight and obese patients in the pediatric population is determined by BMI percentiles as greater than the 85th percentile or greater than the 95th percentile, respectively. At this time, no definition exists for overweight or obesity in children 0-24 months of age. For this population, the patient would be diagnosed with rapid weight gain or above expected weight gain velocity for age. For more details on diagnosis overweight and obesity, see Chapters 10 and 25. Growth assessment is an essential component of a thorough nutrition assessment for all pediatric patients. Monitoring weight, length or height, and other anthropometric measurements provides important insight into nutrition status and nutrient needs. Serial measurements are beneficial in identifying trends over time and allow the dietitian to intervene when patients are not following their growth curves. Information gathered and calculated in the growth assessment can be used in the nutrition diagnosis, nutrition prescription, and nutrition interventions. Patients requiring nutrition reassessment will also require reassessment of growth status.